Hey everyone, and welcome. Today we're going to dive into a topic that is just absolutely fundamental for every single medical student, the physiology of normal labor. So what we're going to do is break this whole thing down into clear, high-yield concepts that are really going to stick with you, not just for your exams, but for your clinical practice too.
All right, first things first. Let's clear up something that trips up so many students. You hear labor and delivery thrown around all the time, right? Maybe even used interchangeably. But are they really the same thing? Well, in obstetrics, nope, not at all. And getting this distinction right is crucial.
So check this out. The easiest way to think about it is this. Labor is the whole journey. It's the entire process with all the contractions and cervical changes. Delivery, on the other hand, is the destination. It's the outcome, that final moment the baby is born. And here's the kicker you need to remember for your exams. You can absolutely have a delivery without labor. Think about an elective C-section. But the process of labor has to end in a delivery.
Okay, so here's the game plan for today. We're going to start by really decoding what normal labor is. Then, we'll look at the hormonal spark that kicks everything off. We'll get into the nitty-gritty of uterine contractions, the engine of labor. After that, we'll walk through the 4 clinical stages of the journey. And finally, we'll wrap up with the key exam takeaways. Ready? Let's go.
All right, let's jump right into Section 1 and build a solid foundation. So what do we actually mean when we say a labor is normal? Well, there's a medical term for it, eutosia, and it has a very specific checklist.
Okay, so for a labor to get that eutosia stamp of approval, it's got to check all 5 of these boxes. It needs to start on its own when the baby is at term. The baby has to be head down, that's vertex presentation. It has to move along at a good pace, not take too long, and wrap up naturally. And most importantly, without any major issues for the mom or the baby. If even one of these isn't met, well, then we're talking about dystocia, or abnormal labor.
You've probably heard of this, and it's super important. The success of any labor boils down to these 3 Ps and how well they work together. First, you've got the power. That's from the uterine contractions. Then there's the passenger, which is, of course, the fetus. And finally, the passage, which is the mother's pelvis. All 3 have to be in perfect sync for a successful birth.
Okay, this next part is, I think, one of the coolest questions in all of medicine. What actually flips that switch and starts labor? It's not just one thing. It's this incredible, beautifully orchestrated hormonal cascade.
So it's not just one thing. It's this incredible hormonal dance between the baby, the placenta, and the mother. You've got all these key players on the field. And what's really fascinating is that a lot of the evidence now suggests it's actually the fetus, the baby itself, who's the one that initiates this entire chain reaction.
So, the leading theory right now, and this is pretty amazing, is that the maturation of the baby's own HPA axis, the hypothalamus-pituitary-adrenal axis, is the main trigger. You can see it right here. The baby's brain and glands release a series of hormones ending with cortisol, and that cortisol crosses over to the placenta and basically says, okay, it's time to go.
Okay, this slide, you're going to want to screenshot this. It's super high yield because it puts all the pieces together. Let's follow the chain of events. So that fetal cortisol hits the placenta. What does the placenta do? It cranks up production of estrogen and prostaglandins. At the same time, the influence of progesterone starts to wane. This whole hormonal shift is the secret sauce. It makes the uterus super sensitive to oxytocin and gets it all revved up and ready to contract.
So, if you remember one thing about the hormones, remember this. I want you to picture a seesaw. For most of the pregnancy, progesterone is sitting heavily on one side, keeping the uterus calm and quiet. But as labor gets closer, estrogen starts to rise, tipping the whole thing in the other direction. It's this change in the ratio of estrogen to progesterone that really turns the key, unlocking the production of prostaglandins and getting the uterus ready for action.
Okay, we've got the hormonal spark. Now let's talk about the engine that drives this whole process, those powerful rhythmic uterine contractions that do all the heavy lifting.
All right, this is a classic exam question, so listen up. How do you tell the difference between true labor and false labor, also known as Braxton Hicks contractions? The biggest giveaway, the thing that separates the two, is right here, progressive cervical change. True labor contractions actually change the cervix. They make it thinner, which we call effacement, and they make it open up, which is dilatation. False labor pains, they don't do that.
Now, this is something really special about the uterine muscle. It has this incredible property called retraction.
So unlike, say, your bicep, which contracts and then relaxes all the way back, the muscle fibers in the uterus get a little bit shorter and thicker with every single contraction. It's kind of like a ratchet, you know? It clicks forward and it doesn't slide back. This makes sure every contraction makes real progress.
And because of that ratcheting action, the uterus actually separates into two distinct parts during labor. You get this thick, muscular upper segment, that's the active part doing all the squeezing. And what it does is it pulls up on the lower segment, which becomes really thin and passive. This mechanical pulling action is literally what pulls the cervix open. Pretty cool, huh?
So we've got the engine running. Now how does this translate into what we actually see and manage clinically? Well, we break down the whole journey of labor into 4 distinct stages, and each one has its own specific goal. First up is stage 1, the dilating stage. This is the big one, the longest part, where the cervix goes from being closed all the way to 10 centimeters. Stage 2 is the pushing stage, which ends when the baby is born. Then you have stage 3, the placental stage, where the placenta is delivered. And finally, stage 4 is the recovery stage, that super critical first hour after birth where we watch mom and baby very closely.
Okay, time for some numbers you absolutely need to memorize for your exams. So, for a first-time mom, a prima gravida, you're looking at about 12 hours on average for that first stage, but for a multiparous woman, someone who's had a baby before, it's way faster, usually around 6 hours.
And guess what? We see the same pattern in stage 2. For a prima gravida, it might take up to 2 hours of pushing, but for a multiparous woman, it's often as quick as 30 minutes. Again, these are key numbers to have in your back pocket.
Whew, okay, we have covered a ton of ground. So let's boil it all down to the absolute must-know high-yield facts for your exams. This is the stuff you really need to lock in.
All right, here's your final checklist. If you're cramming the night before an exam, this is the slide you need. Remember, labor is the process, delivery is the outcome. Normal labor, or utopia, has those 5 specific criteria. The key hormonal trigger, that shift in the estrogen to progesterone ratio, all kicked off by the baby's HPA axis. True labor means progressive cervical change. The uterine muscle's special power is retraction. And finally, know those stage durations and never forget the 3 Ps: power, passenger, and passage.
And that's the whole story. You see, normal labor isn't just something that happens. It's this beautiful, intricate physiological cascade. It all starts with a signal from the fetus, gets powered by the unique engine of the uterus, and moves through a predictable set of stages, all to accomplish one amazing thing: birth.
So I'm going to leave you with a question to really connect this physiology to your clinical rotations. Now that you get the why behind it all, how does knowing about these hormones, these muscle mechanics, and these stages actually guide what we do for a patient in labor? How does it help us decide when to step in or tell us when something's going wrong? Really think about that. Thanks so much for joining me.